So we all have different views, and Randy was giving your view of the way he sees MAS, or the term MAS. So I see the term MAS down here as the HLH secondary to rheumatic disease. I think we should distinguish it. And I think we'll get, the more we study the biomarkers, the more we understand the pathogenesis of these different ways to get to HLH. I think that what we call rheuma HLH or autoinflammation associated HLH will turn out to be slightly different in the ways we get there. A couple of years ago, last year, Alexi and with Alexi and Anna Karin, we depicted this way to get there. Let's put it this way. So you can get to this vicious circle of macrophage activation and T-cell activation with overloads of cytokines and interferon gamma in, say, two different main ways. One is autoinflammation induced by your ability to hyperactivated macrophages or by monogenic defects in cytotoxic genes or in genes related to the cytotoxicity pathway, the lower part of the slides. Obviously, the great majority of the patients do not get there for one single gene. They get there for multiple genes, including the predispositions of heterozygosity for known cytotoxicity gene, as Randy alluded to. So this is a simplified way of what Randy was telling you, and I'm a simple man, and I like to stick, for now, to use the term MAS to define, to identify the secondary HLH, secondary, to rheumatic diseases. I think using the word MAS in general is going to be misleading a little bit. Also because people are going to use the MAS classification or diagnostic guideline to diagnose secondary HLH, and that may not be proper. So we know that gamma is a target because has been known by, I think, a decade now, that gamma is elevated in patients with primary HLH, and that neutralizing gamma is very efficacious in models of primary HLH. There was a presentation at the last histiocyte meeting, which I did not attend, to tell you the truth, but I got pictures of illegal picture with permission for Michael Jordan to be shown, very bad quality pictures, showing that if you do neutralize interferon gamma, either early, day 5, preventive treatment, or late, day 11, a treatment protocol when the mice are starting to die and getting sick, you really get a full therapeutic effect in mice. I think this is the new data. I alluded to the data with ruxolitinib. They are much more complicated. I'm going to skip this. So what has happened in the last year? We have published a couple of papers. One is related to interferon gamma and the chemokines. They have been mentioned as being very high in patients with MAS, but not during active systemic JIA, and their correlation with a number of laboratory parameters of the disease. The work is shown in a poster there. One little piece of information more comes from Cincinnati. Grant, you're supposed to say something now. Yes, please. Either you come here or you get a microphone quickly because we are running over time. Just right.
So, and then we also have a poster looking at bone marrow macrophages in a patient with sort of very early subclinical stages of MAS. Did not yet have sort of overt MAS, but histiocytic expansion, mild laboratory features, and in that we already see this induction of interferon response genes significantly in a population of those bone marrow macrophages. So even at those very early stages before overt clinical features of MAS, we're beginning to see this emergence.
And some of the data are shown in the poster over there, so if you are interested in more information, just go there. So what Claudia has done is gone back. Claudia's sitting there. She's sitting there, so she knows more than I do. And she has looked at whether we can predict who is going to be at risk for MAS by looking at the levels of these 4 things when the patient have active SJIA, but they do not have clinically overt MS. And there is a trend, again, with IL-18, which we haven't measured in too many patients yet, but we are doing, trying to do our homeworks while we speak. It looks like there might be something telling you that this patient might be slightly different in their ability to activate IL-18 production and the interferon gamma pathway. more to come. The other paper we published was the paper published just a few weeks ago regarding the effect of interferon gamma neutralization in mice with, let's call it a murine model of MAS. In which essentially Juicy, again she's sitting here, has looked at the ability of neutralization of interferon gamma to make things better for the mice, and have looked at interferon gamma related events in target tissue, particularly liver and spleen. And I'm showing to you a couple of data here showing increased activation of STAT1, phospho-STAT1, in the liver and in the spleen. And this is particularly prolonged activation, as if these mice cannot control the activation induced by a toll-like receptor ligand in the high background of interleukin-6. And she went back to a couple of patients that we have the chance to study. This is a patient from Padova, northern Italy. She looked like a classical systemic JIA, complicated at onset by MAS. She was started on treatment and she developed severe liver involvement, severe enough that the treating physician were prompt to do a liver biopsy. And when she was on treatment, when the liver biopsy was performed, treatment with glucocorticoid, high dose, and anakinra. And this is what Juicy found. She looked at the mRNA expression level of a number of cytokines, including the known inflammatory suspects, including IL-1, IL-18, IL-6, TNF, and you name it. And there was essentially very little increase. However, the interferon gamma pathway and the interferon gamma related induced genes were highly upregulated in this patient, despite being on treatment. We have had the chance in Rome to see a boy who has an unknown disease, 3 previous episodes of severe HLH, 2 of them requiring ICU admission. With response to standard treatments, he made it quite well. Presented recently with abnormal liver function test, high ferritin. He was fine, no fever, it was perfect, normal blood cell count, but we knew what was going to happen. We wanted to start treatment. We wanted to see the biopsy of the liver, so we did the biopsy. And again, there is a break in the scale. The overexpression of the interferon gamma-related gene was incredibly high compared to the other standard inflammatory genes. And this was without any treatment. Both patients had phospho-STAT1 hyperphosphorylated in the liver. And this is our patient in Rome, in which we had the chance to track CXCL9, CXCL10, ferritin, and IL-18 before and during the episodes. And you can see that really CXCL9, plasma levels of CXCL9 reflected the event in the liver in the absence of any other sign of systemic inflammation or systemic involvement in this patient, suggesting that these biomarkers do reflect what happens in target tissue. Now, to Emapalumab, as quickly as I can. Emapalumab is a new name of an IO501, which is a fully human IgG1 binding interferon gamma, neutralizing interferon gamma. There is an ongoing study, phase 2-3 study, which is close to being closed. Open in Europe and United States. It's recruiting children with primary HLH as first line or as second line. This is the last recruitment update on the patient population. It's 34 patients being recruited, 28 were found to have mutation in known HLH genes, but 6 were found not to have known mutation, therefore by definition secondary. 12 of them had CNS involvement. That's a very high percentage, and they have failed all sort of first-line treatment that are listed there. I don't have very recent efficacy update. This is the same update I showed here in this very conference last year, so I'm going to skip the slides. It's beneficial effect on neutrophil, platelet counts, ferritin, and you can taper glucocorticoids during treatment. This is all I can say about efficacy now. This is the next development steps. The phase 2 study is continuing, phase 2-3 study is continuing recruitment to achieve the target number of evaluable patients. A biological licensing application filing is in preparation in the US. There is a new protocol in primary HLH to be launched in Europe and in United States and Canada. And there is a pilot study just opened in Europe in MAS in the context of SGIA. So before going to the way we designed the study and the way we select the dosing regimen for MAS, I'd like to tell you brief two things about some compassionate use. We have been discussing compassionate use. Today, we have treated two patients with an LRC4-induced disease and active refractory HLH. One of them had a very good response, the one I showed to you last year, I think. The second one had a good response, but is not yet completely out of the disease. We have also treated another patient, one patient, there's a mistake in the slide, it's only one patient, with a novel autoinflammatory disease, with a novel gene that we have recently discovered, she had active refractory HLH and a very good response to the anti-interferon gamma treatment. So this is the study design. This is going to be a short study with very frequent administration, because we want to make sure that we target the gamma which is being produced in a very elastic manner that we can monitor during the study. Treatment period is going to be, as I told you, very short. The drug is being administered every 3 days. Let me tell you why we chose 6 milligram per kilogram per day as loading dose and then 3 milligram per day, which is very different from what has been done till now in primary HLH. I have to go back to the concept of total gamma, which is something that was defined in mice and is based on this principle. When you inject an antibody in the blood, the antibody will diffuse into peripheral tissue and binds the target, because interferon gamma is produced essentially in target tissue and is not measurable at high levels in peripheral blood. It binds the target and it gets, I would say, it sucks the target back into the blood. And if you can measure this amount of gamma, you are measuring what we call total gamma, which does reflect somehow the amount of interferon gamma that is produced in a whole organism. This is very clear in mice. So if you take a mouse, healthy mouse, resting mouse, and you treat and you just measure gamma, he has a few picogram mLs of interferon gamma, of circulating gamma. You administer a monoclonal antibody to interferon gamma, and what you see is the amount of gamma that is being produced at steady state in that given mouse. Now, in this experiment, we use the CPG, let's call it EDS model, the CPG model, ED apologies, and administered CPG to the mice, and the mice were not resting anymore, they got sick. And this is the amount of gamma. This is a log scale, so this is 170-fold higher. The total gamma that is being produced by the sick mouse is 170-fold higher, as measured by the total gamma circulating in the blood. So this is what happened in a patient that is being treated with with Emapalumab. You see that the initial free gamma is very low. As soon as you give the first dose, thousands of picogram ml of gamma become measurable, bound to the antibody. The patient gets better. Then the patient gets a reactivation due to a couple of infections, and you see total gamma rising again. Okay, so you can track the amount of gamma that is produced in a sick patient. And this is what happens in two patients, for example. You give the antibody. In the patient on your left, gamma was high, was close to 1,000. In the second one was undetectable. Okay, you give the antibody and the total gamma rises up, in the first case to hundreds of thousands of picogram ml. In the second one, we're talking about dozens. If you look at CXCL9, this interferon gamma is actually neutralized because CXCL9 goes down. And therefore, the total gamma, which is bound to the antibody, is not biologically active. And this is also reflected by the fact that ferritin goes down as well, paralleling the decrease in CXCL9. So the concept here is that total gamma reflects better the amount of gamma that is being produced in a whole body compared to free gamma. And the other thing you should know is that the total gamma is obviously higher, much higher than the amount of free gamma you can measure. Thank you very much. I think I will make it. 5 minutes sign showed up. Oh. Anyway, so the other thing is that it is important to understand how important is, the total gamma, because you can predict the amount of target-mediated drug disposition. So an antibody is cleared from the blood depending on the amount of target. The more antibodies bound, the faster the antibody is cleared. And this is called target-mediated drug disposition. So you can envisage easily, if you have a high level of total gamma, your drug is going to be cleared faster, and you need more drug if you want to efficiently neutralize your patient. So this is what you do this is what we see in a real patient. So this patient is, I need a pointer here. Can I have a microphone so that I can move in front of the slide? So I know. So this is the level of the drug. You see the patient is losing drug here because total gamma is increasing. It's losing the drug because of target-mediated drug disposition, and therefore is losing neutralization. CXCL9 goes up again. Okay, if you increase the dose, this is what has been done here, you kind of increase your level of drug. Total gamma is being neutralized, and then slowly go down. Is that clear? Hopefully. So if this is true, then total gamma reflects the amount, CXCL9 reflects the amount of total gamma. So to prove this hypothesis, we measured CXCL9 at baseline, assuming that CXCL9 was being induced by the amount of gamma present in the tissue, and we measured total gamma 48 hours following the first administration of the antibody, and this is what you see. You see a very tight correlation, suggesting that CXCL9 in peripheral blood does reflect the amount of gamma that is present in tissues. And therefore, CXCL9 represents a very good way to estimate the amount of total gamma which is being produced in the body, and therefore the amount of drug that is needed to neutralize efficiently that given amount of total gamma. If you go back and look at the levels of CXCL9 and CXCL10 in the patient with MAS compared to patient with primary HLH, the one that were in the study and the ones that are in the graph that I just showed to you about the correlation between total gamma and CXCL9, you can see that the levels were higher. So patients with systemic GIA produce higher amount of CXCL9 and CXCL10. If this reflects the amount of total gamma, then we need more drug. That's why the study was designed based on this simulation, and this simulation are designed in patients with very high level, the lowest line, very high level of total gamma. They tend to have lower level of drugs. They are predicted to have lower level of drugs by these simulations according to target-mediated drug disposition. And this is designed, and this dosing regimen was chosen to give you a prompt effect, 6 milligram, being able to neutralize the high level of total gamma present in this patient, and then maintain these levels of neutralization even in the presence of high levels of interferon gamma production. So this is the study design. Okay, thank you. I am. So this is going to be the study design. This study is open in Rome, in Barcelona, will soon be open in London, and I don't know where Utrecht is. Are you almost there? And hopefully will also be open in the US and Canada in the near future. I've been very rational, data-driven. Now I'm doing something that is very incorrect, probably. So this is a number, but you can guess from CU what this number is. This is our first compassionate use. And there are times in which we can make a real difference. And for this child, we did make a difference. And although this is not very professional, I like to show it. This is Gigi. This is still wearing a central line here, but then the central line is gone. It's very healthy. Thank you very much.